So I would like to start today by an acknowledgement of country. I would like to commence the formal proceedings by acknowledging the Gadigal people as the traditional custodians of the unceded land on which the symposium today will take place, and of course all of the many lands that you join us from. And we pay our respects to their elders past, present, and emerging, and recognise their cultural and spiritual relationships with the lands, waters, and seas. It is our privilege to learn from their rich contributions to both society and science as we work towards finding more effective ways to help all children with cancer. I also extend that same respect to Aboriginal and Torres Strait Islander people and colleagues here today. So thank you to everyone who has joined us and who will be joining us around Australia for our May. It is May, isn't it? Yes, our May Zero seminar. We're very, very grateful for your participation and attendance. And today, I'd very much like to warmly welcome Associate Professor Rachel Conyers from the Murdoch Children's Research Institute and Royal Children's Hospital in Melbourne. And she is a consultant paediatric oncologist and clinician scientist with a clinical focus on bone marrow transplantation and lymphoma. And she's also the clinical lead of the bone marrow transplant unit at the Children's Hospital in Melbourne. And if that's not enough, Rachel is also the lead for the Pharmacogenomics and Radiogenomics group for the Victorian Pediatric Cancer Consortium, which is jointly funded by MRFF, was funded by MRFF and is actually now joint funded by MRFF and the Children's Cancer Foundation, which is really exciting. And she's also co-chair of the Zero Childhood Cancer program. Zero Childhood Cancer program, Pharmacogenomics committee and working group. So, Rachel, welcome today. Thank you very much for joining us to give us your time to speak with us today. And we're very much looking forward to your presentation, which is Pharmacogenomics Implementation and Discovery in Pediatric Oncology. So take it away, Rachel. Thank you so much.
Thanks so much, Ness, for the kind intro. I'm just going to share my screen. I'm hoping you can see that there. I'm just going to turn some things off. There we go. Is that on the right screen for everybody? Just give me a thumbs up if you're seeing the big one. Yeah. Okay. So yeah, thanks for the introduction. I'm really excited to be here today and share some of my team's work. So as you all know, all of our research starts with a patient. And for me, this patient was a young 8-year-old girl who had AML and had 2 cycles of chemotherapy when I saw her on the ward as a young resident, and she had a 3rd heart sound and had gone into flagrant heart failure. And so chest x-ray showing a massive globular heart, consistent with doxorubicin, anthracycline cardiotoxicity. And this patient has actually driven a lot of my interest in rare toxicities that we see with cancer therapies, particularly this idea of can we actually prevent the sensitivity to these toxicities through genetic screening. And so as people on the call may or may not know that anthracycline cardiomyopathy in its worst form affects only about 2% of patients, but it is incredibly unresponsive to medical therapy. And many of those patients who are in the heart failure stage end up being listed for heart transplant. So this is just to set the scene about adverse drug reactions. We know that adverse drug reactions account for about 30% of hospital admissions, We know that 60% of pediatric oncology patients experience adverse drug reactions during their cancer therapy. What may be less well known is that there are international consortia that have defined genetic variants and indeed metabolizer states for which a medication change is warranted. And those broad groups are the CPIC group and also the Dutch group. We also know that 80% of pediatric patients, when they're screened, will have a high risk variant, where if they were on that medication, they should get a prescription change. And then finally, there's been pretty poor uptake of pharmacogenetics in children broadly in the world, but particularly in Australia. So it probably goes without saying that pharmacogenomics is just more personalized prescribing. So instead of seeing your patient, prescribing them ondansetron, seeing them 2 weeks later and asking them if it's working, you can do a genetic test to see whether they are an ultra metabolizer of ondansetron, in which case they're going to metabolize the drug off and they will have ongoing nausea. So it fits into this idea of really personalized prescribing. I've mentioned the 3 very big groups throughout the world that are defining, that are looking closely at the literature and defining the variants that need actioning. This landmark study came out only about 12 weeks ago now, and it is the first study that's looked to show a reduction in adverse drug reactions when you use personalized prescribing. And it was done in an adult cohort, a very broad cohort, hospital patients, patients attending pharmacists for their common prescriptions, and you had to be over 18. And it was the Dutch group that ran this. It was over 6,000 patients. And what they found is that if you use genotype guiding prescribing, that you did reduce the incidence of clinically relevant adverse drug reactions. So what are the next steps for pharmacogenomics in pediatrics? I mentioned that CPIC, which is a very large primarily pediatric group, have designed and written guidelines that everybody's saying are really good, but not really adhering to. Well, why is that? What are the next steps for pediatrics? So there are some concerns about ontology differences in pediatrics, that there's a potential dynamic expression of the metabolic enzymes across, particularly in the first eight years of life, and a maturity that happens of the drug transporters and their targets. There's also a development of the organs that do the drug excretion and metabolism. So the maturity of the liver and the kidney, which are obviously under development during childhood. Pediatric patients have different comorbidities to adults, different comorbidity indices, and in general, less polypharmacy, although that's less relevant to the pediatric oncology cohort that we're talking about. And obviously diseases of childhood with less environmental impacts, such as smoking or alcohol consumption. What we need to do is develop the evidence for implementation across a high-risk cohort in pediatrics. We also need to educate our stakeholders, and that they are many and varied in prescribing and receiving prescription recommendations. And then one of the biggest hurdles, along with showing a reduction in adverse drug reactions when you use this personalized prescribing, is proving that it's cost effective. And that is one thing that the PREPARE trial I showed earlier hasn't yet been able to do, and it's something that we will be trying to do in the study I'm about to talk about. So the study that we have open at the Children's Hospital in Melbourne, with the plan to hopefully go national, is called MARVEL. It's the long name is Minimising Adverse Drug Reaction and Verifying Economic Legitimacy, and it's been open since March of this year. The hypothesis is that if you are a patient who has an abnormal metabolizer state, where there's an alternative prescribing recommended, whether that's switching drugs or starting at a reduced dose, that if you adhere to those guidelines, you'll have a reduction in adverse drug reactions. and that the healthcare system will have a reduction in treatment costs. This study is a randomized control trial, and it's assessing the impact of implementing that PGX testing across 27 gene drug pairs compared to standard of care. The primary endpoint of the study is a reduction in adverse drug reactions in the two groups that have an actionable pharmacogenomic variant. And as an example of what an actionable pharmacogenomic variant means, if you have a CYP2D6 diplotype that's *1, *1, that means you're an ultra metabolizer. And let's say you're an oncology patient taking on ondansetron, the recommendations would be that you select an alternate drug that's not predominantly metabolized by CYP2D6, and you would take granisetron instead. So the endpoints of the study are looking at the cohort of patients who are in this setting where they have a recommendation for their metabolizer state. How do we grade the adverse drug reactions? We're using the common toxicity criteria for adverse events, which clinicians will know very well. We use them all the time in oncology. And the cutoffs for our study are non-hematological events grade 2 or higher, and grade 3 hematological events or higher. There's a number of secondary endpoints. I've touched on the fact that we want to look at cost effectiveness in the two arms. We also want to look at the prevalence of those actionable medicine gene interactions, the incidence of medication management. How do our practitioners and pharmacists handle those recommendations? The incidence of hospitalization due to adverse drug reactions, and the acceptance and adoptions of pharmacogenomic-led prescribing. This schema just shows you the two arms of the study, and then the two red highlighted boxes are the groups that we're comparing in the endpoint analysis. I just wanted to point out, I mentioned there's 27 gene drug pairs we're looking at. In the standard of care, clinicians on the call would know that we actually only screen at the moment for 2 genes, only in acute lymphoblastic leukemia patients, the NUD15 and TPMT metabolizer states, so that will still exist in the standard of care arm. We will then generate a report, which I'll show you in a minute, using a combination of the CPIC and the Dutch guidelines, and that's provided to their primary physicians. This schema shows you the length of the study. So the adverse drug reactions are recorded initially using the PED-PRO CTCAE. This is a prospective patient-reported or carer-reported survey across 72 symptoms. It's previously validated by the National Cancer Institute, and we generate that via REDCap out to the email address of the patient. And they complete that 3 times over a 12-week period. Within 4 days of having done that survey, our pharmacists lead a semi-structured interview to take those symptoms and make it a CTCAE grade. They're very close, but they're not identical. So it does take a bit of a structured approach to formally CTCAE grade those symptoms. For patients in the standard of care arm, everybody will get their sequencing done at the start, but they will get theirs released after the reporting of adverse drug reactions have been done, after the 12 weeks, whereas those on the intervention arm or the study arm will get their PGX results far earlier. And then finally, after the CTCAEs have been graded, we then want to prove causality. So we want to say that symptom is related to an adverse drug reaction. And we do that using the Liverpool causality assessment tool, at which point it becomes an ADR, which is the primary endpoint. This is a very brief snapshot of the difference between the patient self-reporting survey versus the CTCAE grades. And you can see that the wording is very simple. It's very understandable as a parent. As an example, in the past 7 days, how often did your child feel sick to their stomach? How bad was your child's feeling sick to their stomach? How much did feeling sick to their stomach keep your child from doing things they usually do? And then you would take that into a CTCAE grade, which is a little bit, definitely a bit more defined. This is an example of the Liverpool Adversality Assessment tool. It takes you through a workflow where you can assign a probability to the adverse drug reaction being related to the drug of interest, as definite, unlikely, possible, and probable. And many of our patients will end up in the possible or probable box. The cost-effectiveness arm of this study is carried out using MBS and PBS data, which is retrieved in Victoria from Services Australia and the Centre for Data Linkage Victoria. The economic evaluation will compare the costs and outcomes from the study arm versus the standard of care arm. And the costs will reflect the healthcare service use associated with pharmacogenomic testing, the treatment of any adverse drug reactions that occur for that patient, and their ongoing patient care. When talking to the health economists, our adverse drug reaction percentage is not particularly translatable to a economic analysis. So and what they like to do is look at a difference in quality of life, which obviously the two interplay with each other. And so to monitor their quality of life, we're using the CHU9D, and that's done at baseline, at week 12, and then 12 months. And it's again administered via email through REDCap. The bioinformatics pipeline. So one thing we really wanted to do was be able to use the whole genome sequence that all of our patients across pediatric oncology are now being afforded through the Zero program to be repurposed for PGX interpretation. And so the first step is that the patient undergoes or donates a blood sample in both arms, and it undergoes whole genome sequencing. We have then developed a pipeline for bioinformatic analysis and diplotype calling, and that's largely, the tools that we use in that are largely led by the gene that we're analysing. So as an example, CYP2D6 is a very good tool called Cyrus that has a really high sensitivity and specificity for CYP2D6 diplotype calling. Our bioinformatics team then integrate the diplotype with the current international guidelines, and we have a governance structure around that. And then we have a multidisciplinary team meeting with the academic pharmacist, our research assistant, bioinformatician, and myself weekly, where we go through the patients that have come through in the last week. We go through their medication reconciliation, we define whether it's an actionable PGX or not, and we go through the results of the report before confirming and verifying it, at which point it gets sent to the patient's primary consultant. Go back. This is an example of that report, just to show you that on the left are the abnormal metabolizer states. So the physician is provided with the implications and the recommendations for dosing as per the CPIC guidelines. And it's done per drug because we thought that was easier than doing it per gene. It's much more, as a clinician who may not understand pharmacogenomics, you know how to look directly for the drug that the patient might be on. And then on the right-hand side, at the end of this report, are all the other genes that we're looking at and the metabolizer states and medicines to look for in the future. This is an overview of the pharmacogene drug pairs that we're looking for in MARVEL-PIC. And I think one of the take-home messages is that I think before I started this project, I didn't quite realize the number of medications that we use that actually do have international recommendations. So Allopurinol, obviously, we use a lot for tumor lysis syndrome. We use proton pump inhibitors for our patients that are on longer-term steroids or potentially in transplant, so omeprazole and pantoprazole. It's not infrequent that we would use an azole for mold prophylaxis like voriconazole. Our antiemetics, which literally every patient is on, ondansetron and tropizatron have recommendations attached to them. Tacrolimus, although less patients on that. Our G6PD status, most places would be doing, but obviously there's the toxicity associated with respirocase there. Amikacin for sensory neural hearing loss associated with the MT-RNR1 variant. And then those that we're probably most familiar with, NUD15 and TPMT, and for some of the solid oncologists and pharmacists, UGT1A1 for irinotecan for relapse disease. So it's not infrequent that we find our patients are on a medication that we need to look at these results for. This is an overview of the first 22 patients that went through the study. It shows you the randomization between arms. And then the next blue box show when a high risk variant was found. So that means that they have a metabolizer state that warrants a medication change, but not necessarily that they were on that drug already. So you can see that 80% of patients end up having a high risk variant in keeping with the data already shown out there. And then of the patients that had a high risk metabolizer state, 30% of them, or a total of 30% in each study arm, were on a medication that warranted an actionable change at that time point. This is an overview of each gene and the normal versus abnormal metabolizer states that we're seeing. So to give you an idea, the dark green are normal metabolizer states. The red or orange are abnormal metabolizer states in the intermediate or poor function. So they're accumulating drug and toxicities. And then the blue at the top are the ultra metabolizers. So they're just metabolizing off the drug and probably not having any efficacy from the medication. The one that is the standout and needs to be explained in a bit more detail is the CYP3A5, where you can see that 85 or more than 85% of patients are poor metabolizers. The common dosing that we use for all patients, independent of knowing their metabolizer state, is based on a poor metabolizer, is based on inferring the patient is most likely a poor metabolizer. So the ones that are actionable in that group are actually the ones that are normal metabolizers, the 12% at the top, and would need a higher dosing to start with. I think I've said all of that. There have been 42 adverse drug reactions that have been formally graded. This is now about 4 weeks old. 30% of them had a grade 2 adverse drug reaction, and 15% of them had grade 3 adverse drug reactions. And I just wanted to give a couple of clinical scenarios as to how this is playing out. One patient was enrolled prior to stem cell transplant. They were a CYP2D6 ultra rapid metabolizer. That meant that ondansetron that was part of their protocol was ineffective. And so we prescribed that patient granisetron prior to starting the transplant, which likely reduced her nausea and vomiting. The second patient presented to ED with gastritis. That patient was having steroids and was on a standard dose of omeprazole. She was a CYP2C19 rapid metabolizer, in which case the guidelines recommend a higher dose of omeprazole, 50 to 100% higher dosing. That was increased and her gastritis resolved. I think the important take-home point is that often the quality of life of our patients is quite dramatically affected by the very simple supportive care measures that we're using. So it's been really reassuring to see it play out in practice. The next part of this talk I wanted to talk about is really discovery pharmacogenomics, which arguably is the harder part, identifying new genetic causes of rare or high-grade toxicities. It becomes very relevant because as we continue to successfully cure patients, then we have a much larger survivorship, much larger number of patients surviving, and we need to improve survivorship period looks like. Treatment-related mortality is when deaths occur in the absence of progressive cancer, and as an oncologist, treatment-related mortality or toxicity mortality is sometimes the hardest to deal with. I mean, definitely as a parent, but also as a treating clinician, it's very hard to reconcile. It's reported in some international studies as high as 26%, depending on the age group that you're treating and the type of protocol you're using. And it can relate to infections, as we know, sepsis, or drug or end organ toxicity. And much work has been carried out in the last 3 or 4 years to define unacceptable toxicities, so morbidity rather than mortality, that would define a group of illnesses that you got as a result of your cancer therapy, that if you'd known you were to get them, you may not have gone ahead with your cancer therapy at all. And this group is, this group of patients and this group of toxicities is really important to describe, because you're essentially measuring severe toxicity-free survival, which is what we want to aim for all of our patients. And the first iteration of this was published in Lancet Hematology last year, at the start of last year, I think, midway through the year before, and then we refined it just recently. And they're things like blindness, renal failure, insulin-dependent diabetes, osteonecrosis requiring a hip or a joint replacement. And the idea of this is that we would then do pharmacogenomic discovery to see if we can actually isolate genetically the patients that are at most risk of these endpoints. So I wanted to talk today about anthracycline cardiotoxicity, which is a particular love of mine. And coming back to the patient at the start who really spiked my interest in rare toxicities. Anthracyclines, as many of you know, are used in 70% of our protocols at the moment. They're a very effective therapy for cancer. The cardiomyopathy that you can get from anthracyclines is really variable. So you can actually get an acute pericarditis with treatment. You can get a subchronic 1 to 3 days after administration. You can get an early kind of chronic picture, which happens less than a year after treatment. And the one that we're probably most familiar with is the late onset chronic cardiomyopathy. Doxorubicin works by inhibiting topoisomerase 2B, where the repair mechanism is initiated, but it fails, and then there is subsequent cell death and apoptosis, which is probably why we worry so much about the very young hearts, because they only have so many cardiomyocytes that are going through their phases of hypertrophy. And so apoptosis for them is a very big hit on their final long-term organ function. There have been multiple genes that have been highlighted as potentially predisposing or protecting against anthracycline cardiotoxicity, and some of them influence how the drug gets into the cell. Some of them influence how the drug gets out of the cell. Some of them interrupt directly with the sarcomere. Some of them are involved in inhibiting or increasing the reactive oxygen species that are let off from the mitochondria. So lots of different hypotheses and quite a number of ways in which this toxicity could eventuate. Many, many years ago, we ran the ACTIVE study where we took a cohort of survivors of childhood cancer, and we subdivided them into groups of cardiotoxicity based on their ejection fraction. And we have followed them over time. We had approximately 20% of patients had at least a drop in their ejection fraction below 50%, or their fractional shortening below 27%. And then approximately 7% of them had severe toxicity, so a fractional shortening less than 24%, with 2 patients in that cohort listed for heart transplant. We sequenced all of those patients and then put them through a bioinformatic pipeline to see if we could find causative variants. And our sort of pipeline for whether we called something as potentially causative were if the genes had to be expressed in the heart. There was no point if they were just expressed in the liver. They had to be only found in the patients who had severe anthracycline toxicity. And then the last bit was if they hadn't previously been described, did they have what's called in silico pathogenicity, which is basically, does a computer think that this could cause disease? And when we profiled, of the 16 patients that had severe toxicity, 9 of them had variants in cardiomyopathy genes, and in fact 5 of them had cardiomyopathy genes that had been previously described as truly pathogenic. And so that was incredibly interesting to us, although the biggest deficit of this study was not having, because of money at the time, we had to pool our controls. And so what we're trying to do now through a national approach is increase the numbers so we can do individualized sequencing of the control group, and we can start to prove whether this is in fact true. One of the most common, well, in 2 of those high-risk patients, we saw that they were ALPK3 deficient. And that has actually been previously described. There is a type of cardiomyopathy that gives you a dilated cardiomyopathy that's been described in ALPK3 families. And so the way you can start to look at this in the dish is to take patient cells, which we do, and then, I'm going to go back to that, and then use their pluripotent stem cells to put them through a maturation step and develop cardiomyocytes. So you can essentially grow a scaffold of heart cells in the dish, and then use a series of tests to see what the effect of the anthracycline is. And this is just showing you really the phenotype in the dish, but this is a wild type iPSC cell line, set of cells. And then in the one on the right, you can see this is an ALPK3 cell line, which you can see is not contracting anywhere near as nicely. So I mentioned that you can have a look at what happens in the dish with ALPK3 deficiency and also with the exposure of doxorubicin. This shows you, this is a measure of calcium handling, which you remember in that slide where I showed the different mechanisms that cardiomyocytes can undergo damage. Calcium metabolism is one of them. It helps how they contract. And what you see is in the ALPK3 null variants, that you have decreased calcium handling, which will affect the efficiency of the cell. This dose response curve we did in a set of isogenic pairs, so wild type, homozygote and heterozygote for ALPK3, and expose the cell lines to anthracyclines to see if we can mimic in the dish what we see in the patient, which is cardiotoxicity. And you can see that there is a shift to the left with exposure to doxorubicin, basically showing us that these cell lines have a sensitivity in the dish, exhibiting the phenotype that we see in the patient. So I guess the main why that's important is that when you do just sequencing, you only prove association, not necessarily causation. When you have a functional model that you can then work with, you are able to prove that causation. So our hypothesis at the moment is that for some patients, and it's not going to be all patients, it's going to be a small number, the exposure to the cardiac stress of the anthracycline acts as a second hit to an already genetically susceptible individual. But we definitely need more numbers. And so the National Heart Foundation study that we're running with colleagues from Sydney Children's Network and also Chris O'Brien Lifehouse, some of which may be on this call, is really trying to boost those numbers so that we can start to look in a dish and at the genetics more carefully. And this is just to show that particular study, which is national and has a range of approaches to it, but one of them being the functional assays. So the key messages from my talk today. So pharmacogenomic testing can help guide the choice of medication for all of our patients and appropriate dose changes in pediatrics. Pharmacogenomic testing increases the likelihood that each patient receives an effective medicine, which is something I think we don't really screen for very well at the moment. Using nausea as an example, our approach is to always just add another antiemetic, whereas with personalised prescribing, you may just drop the antiemetic you're using and move on to a different one. Benefits are likely to the patient. We've already seen that even in very simple terms in our study that's currently running. And it remains to be seen whether it's cost effective, but we are hopeful and hoping to prove that. Discovery for pharmacogenomic variants causing rare or severe toxicities is really crucial to getting our survivors to have severe toxicity-free survival. But it is definitely something that needs to be collaborative. We will have to team up with our international partners just because of the rarity of each toxicity that we're looking for. So I want to acknowledge, first of all, our patients and families who have really contributed to this, this work over the last 8 years, and definitely provided the inspiration for looking at rare toxicities. I want to reference our pharmacogenomics team, many of which are on the line at Murdoch Children's Research Institute, and also VCGS, who have been really really worked so hard at developing this protocol and developing the pipelines and the governance, and it's really, they're a wonderful team to work with. The heart disease group I've been working with for many years, including my colleague in the lab, Dave Elliott, and then our more recent collaborations with Peter MacCallum Cancer Centre, Leiden University Medical Centre, and St Jude's. And that's the end of my talk. I'm very happy to take any questions.
Rachel, thank you very much. That was terrific, and certainly a very clear outline of pharmacogenomics and how we're using it or would like to be using it today for kids with cancer. Now, we have plenty of time for questions, so please pop your hand up or pop a question in the chat, and Rachel will be very happy to answer some of those questions. I'm going to ask a question while people are thinking. And, oh, sorry, Mark, I just saw you there. I'll go first. Chair's prerogative. This is a very simple question, or maybe it's not. How long do you think it will be before we're doing this routinely, Rachel, for kids with cancer? Or anyone for that matter?
Yeah, so I think, I mean, pharmacogenomics, looking for the diplotypes that are already have international guidelines, I think we should be doing that currently. So my hope is that our MRFF is funded, and then we can open this up to all of our Australian patients. There's really no reason I mean, there's academic reasons for proving that there's a reduction in adverse drug reactions and that it's cost effective. But on the other hand, there's also an argument if we're doing sequencing anyway that we should provide these results. And that's sort of broadly across newborn screening and, you know, acute care genomics as well. The rare toxicities, I think, is a really difficult thing to study. And what remains to be seen is how many sort of monogenic causes there are, as opposed to patients who might have a number of genes that have a slight alteration that therefore results in them being predisposed. And I think my learnings over the last 8 years is that that forming collaborations with the big groups like the Ponte de Legno group is kind of the way forward for contributing patients to a large study, so that we can at least prove the association a bit quicker. The causation is a really interesting thing to think about, what models that we use. You know, there are a number of pluripotent stem cell models you can use, but for different toxicities, but there's other things that are incredibly hard to model, like neurotoxicity, as an example. So the sort of functional analysis needs a bit of thinking and probably is a bit more long-term.
Thank you, Rachel. Mark, Callie.
Hey, Rachel, great talk. Really nice to hear it. I don't think we've met, so my team's responsible for generating the genome data for 02. So I don't know if you're ready to answer this question, but how do you best want to work with 02? I'll leave that open-ended at that.
So very happy, and in our PGX0 working group, we've kind of had discussions around where this might lead. We are keen to commercialize this approach so that it's got, you know, that's not a research project ongoing. But, you know, ideally we would use this pipeline to report back to zero. And, you know, I think if we get the national study up and running, it will prove some feasibility around that for sure.
I might have missed it. Were you doing the cheap targeted test, or whole genome, or both?
Whole genome. So
Zero's data, right? Or your own data?
No, so we're using our own,
Okay.
So our own pipeline. But there's no reason why we couldn't marry the two together. Yeah,
it's probably not the right forum to work that out, but just want to say we're willing to try and work that out with you.
Thank you, Mark. Sounds great.
Absolutely. Do we have more questions for Rachel? Don't be shy. Your talk was so clear. Your presentation was so clear, Rachel, that no one has any questions.
Oh, it might have been just really unclear. That's always.
It was very clear. Very clear to me, and fantastic to see the work that is progressing in this area. You know, for someone who was dabbling in pharmacogenomics, you know, 10, 12 years ago, and probably more than that actually, it really has come a long way in that time. And it's really, really terrific to see some of this work right now.
Yeah.
And hopefully we can harness that over time to really enhance how we move forward. I think one of the other things in terms of cost effectiveness, there is a movement towards, certainly through MSAC now, there's a movement towards using real world patient evidence and impact from that perspective versus clinical, not necessarily clinical utility, but cost utility and cost effectiveness. And they are starting to consider factoring in that real world patient evidence and impact to their assessments that they do for MSAC for Medicare testing. Not the Medicare testing is Medicare item numbers are always that useful, because for the children at least, because they are generally inpatients, but over time perhaps that can change too. Yeah. But we are starting to see that being demonstrated. I think that's a really important thing for all of us to remember. the impact and patient evidence is becoming something that they will start to consider over and above cost effectiveness. Callie again, or are you still up? Yeah.
It's a new one. Like you mentioned newborn screening, and I know there's Genovic. I know a little bit about that, but are you got plans in place to do PGX at birth? That sounds really exciting.
Yeah, so the MRFF we put in, which I just saw Marion's on the line, she's involved with that. One of the call was not for pharmacogenomics in oncology, it was in sort of broad groups. So the newborns, there is a newborn screening and MRFF through VCGS, which is with Sebastian Lunke that we work really closely with. So one of our proposals was to run the newborn screening cohort, which is about 1,000 patients through PGX, and look at, one thing is prevalence, but also try and use their databases to look at who would have actually used that data should it have been available to them. And the other cohort was the acute care genomics cohort, which is a group of patients who Australia-wide who present to an intensive care unit with a often in the first year of life with a terminal illness that's undefined and likely to be monogenic. So, you know, intractable seizures, something like that. And looking at in that cohort that are probably going to have polypharmacy, how useful could PGX have been as well? So just trying to think a bit broader than our polypharmacy group, but I think there's definitely, there's definitely interest.
Yeah, I imagine the anti-epileptic drugs are a particularly useful area. Yeah.
And also the anesthetic. I mean, there's anesthetic implications as well. There's a couple of antiarrhythmics. You know, the anticoagulants, I guess, are less relevant to our cohort, but certainly become relevant as you get older. Yeah, it's super. I mean, I find it super interesting. It's not everybody's cup of tea.
Definitely have an interest from years ago that didn't quite get off the ground. But this last question, evidence for somatic evolution of PGX alleles, loss of alleles in tumours and things?
No, they think it's pretty, so I don't, not in tumours, I don't know, but in the body thought to hold quite well. But having said that, one of the studies that I didn't mention today that we're just writing is about this idea of phenoconversion, where your genotype doesn't actually mimic what you do in real life, to quote Bluey. So you can dose patients with a probe drug to test different enzymes like CYP2D6 or CYP2C1 line. So use things like ondansetron or I always forget the name of this drug. If Ben Felmingham's on the line, he can tell me what it's called, the one I always forget the name of. Anyway, and you can use them, you can look at their metabolism. And
dextromethorphan.
Thank you.
No wonder you can't remember it.
That just doesn't stick in my head. But you can look at the metabolism and essentially what their phenotype is, and then marry the two together. And there's some evidence that in patients who are older, patients who have more disease, patients with inflammation, that they probably don't mimic their genotype in terms of what their enzyme activity is doing, which I think has huge implications to potentially to outcomes in cancer therapies if you can show that over the time of their cancer therapies, they're actually over metabolizing or under metabolizing a lot of the time. So that's sort of, I think that speaks to your question, is there somatic changes in the genes? Maybe not, but there's definitely influences on how well those metabolism enzymes are working.
Maybe with matched methylome and expression data, we could have the keys to unlock that. Yeah,
we should talk. We should, that study is called Pegasus. Yep, they've all got weird names. We're going to get sued by Disney, we think.
We have a question from Sarah O'Sullivan. Go ahead, Sarah.
Thank you, and thanks, Rachel, for your presentation. I'm very much here to learn. Pharmacogenetics is way out of my comfort zone. I am a genetic counsellor, and I was just thinking, oh, sorry, cut you off. What did you say?
Not so out of your comfort zone, though, if you're a genetic.
Well, pharmacogenetics is certainly something I don't have much experience with it at all, but I was just thinking in terms of the familial implications, particularly just then when you were talking not only about the drug metabolism, but things like anesthetic implications, arrhythmias, etc., and whether this the findings in a child are discussed in terms of potential risks for parents or other siblings, and if so, who does that? Who does the testing, who does the discussion, etc.
Yeah, so in this project, so for a number of reasons, but the main one being that we don't want to influence, we want to find that primary endpoint. So we don't want to influence what the primary practitioner does in terms of, obviously we give them a report, but we don't say to them, you must adhere to this report, or you must counsel your patients this way or that way. So we haven't developed a formalized approach to counseling patients yet. However, having said that, there are Claire Moore, who's actually presenting this study in Denmark in a few days, and is in Denmark. Part of her PhD is looking at the barriers and enablers to pharmacogenomic testing, both from a healthcare professional and a consumer perspective. And she's just completed a systematic review looking at what those barriers and enablers are. And many of those themes come up. So, patients worried about implications for insurance and healthcare coverage, implications for familial, does my mum have it, etc. The healthcare practitioners' worries are, well, I feel out of scope here telling people about pharmacogenetic testing. Who does that actually sit with? The next part of her PhD is going to be screening, doing a survey of healthcare professionals and consumers to really fine-tune those areas using kind of focus groups, and then trying to overcome some of those barriers and enablers. But I think that question around how do you do it best, and what are the, do you do it with a genetic counsellor? Are pharmacists actually best placed to do this given their knowledge of drugs and metabolism? Is it the role of the primary physician? I think that all needs to be parsed out. And quite surprisingly, there is no evidence in the literature around, people talk a lot about education and what needs to happen from an education perspective, but there are no papers in pediatric oncology about how you actually educate for this, and how well, what actually works for educating around this. So there's a lot of work yet to be done. It was very long-winded and basically said we're not doing it, but hopefully that was useful.
It was, thank you.
All right, do we have any final questions? If not, we will wrap up because it is 5:51, so the timing is excellent. It doesn't look like it. Speak now. No, we're good. Rachel, thank you so much. That was a really educational experience for all of us. It was many of us, I'm sure, and it was really a delight to have you come and speak with us today. So thank you for your time and your effort that you put into that. I'd like to let everybody know that our next speaker will be Professor Deb White on the 28th of June. So mark that in your diaries, and we'll make sure we get the meeting invitations out to you. And of course, as we always say, we absolutely will welcome speaker nominations. So we'd love to hear from you if you would like to suggest a speaker for any of our monthly seminar series. So once again, thank you to everyone for joining us, and thank you, Rachel, for speaking with us today.
Yeah.
Have a great week, everyone. Bye.